Our next speaker is Dr. John Bilezikian. John's at Columbia, a professor of medicine, and his specialty is in osteoporosis. He received his MD at Columbia and his internship and residency, and then he was a fellow at the NIH. He's been a recipient of a number of awards, a number of book chapters and publications. And he's going to speak this morning on new and emerging therapies in osteoporosis.
Well, Dave, thank you very much for inviting me to be part of this very impressive program. As you know, and this is in the realm of true confession, I am not a rheumatologist. I am an endocrinologist, but the area in which I'm interested in obviously is an area where many of you are, because it is in the area of osteoporosis and other metabolic bone diseases that actually are interfacing between our two specialties. I'm going to give two talks this morning. This first talk is entitled New and Emerging Concepts in Therapeutic Approaches to Osteoporosis. And what I hope to do is to bring you all up to date into where this field is going with regard to new and emerging treatments. My next talk will talk about where this field is going apart from therapeutics, and that is like a year in review with regard to bone. Okay, so we have, as you know, a number of very good treatments for osteoporosis. In yellow on this table are the drugs for which I believe there is good evidence for global efficacy. And we actually start with estrogen. People don't think or use estrogens anymore, but there really is pretty good evidence for global effects on fracture reduction at the vertebral, non-vertebral, and hip areas. The bisphosphonates, alendronate, rozedronate, zoledronic acid, and denosumab are the drugs that, if you are looking for an agent that will reduce fracture risk uniformly, those are the drugs we usually focus on. There are other drugs on this list that are also very good, although the evidence for what I just pointed out may not be as strong. So with this nice menu of options, you may ask, well, why are we wanting to do better? And this slide indicates why. They are helpful, but none of these drugs provide complete fracture protection. There are adverse events for any drug, and with regard to our field, some of these events, I would say, are hyped by the media, but some are true. Some of these drugs are very expensive, and because of the major advances that have occurred in bone biology and the easy translatability, if you will, from those basic advances to the bedside, as it were, makes it desirable for us to think that there may be new and better therapies on the horizon. So I'm going to cover this, and before I go further, let me just point out, those of you who are following along on your syllabus, and you liked every slide to be shown, and no slide that isn't on your syllabus not to be shown, you're going to be very disappointed. The tyranny of technology. We always are changing our slides, making them better, taking some out, putting some in. So don't worry. I will cover everything that you want me to cover, even though it won't be strictly adherent to the syllabus. We're going to cover anti-resorptives, anabolics, combination therapy, and new classes. So let's start with denosumab, a drug that all of you know. This is a drug that was developed, again, from one of those newer advances in bone biology of not more than 20 or 25 years, when we became aware that the osteocyte was the source of a very powerful cytokine, namely rank ligand, and this cytokine has a powerful effect